Good evening. I'm Jim Acabellis, the Senior Vice President of Government and Regulatory Affairs at the Connecticut Hospital Association, and I'm here to testify on two Certificate of Need bills, Senate Bill 440 and House Bill 5613. We, for many years, have supported the Certificate of Need program, and I think it's fair to say that our support has been challenged in the last couple of years. The CON should be a tool to support world-class healthcare, but the current process is broken with excessive delays and administrative burdens. At its heart, the Certificate of Need program should be looking and focusing on patients and patient access. And it should be the balance. And as I was writing my comments this morning, just before Dr. Gifford and AG, the Attorney General and Senator Looney, who used that word a lot, we wholeheartedly support it. It's a balance between regulatory oversight and providing access to care. We support Senate Bill 440. It takes a significant step toward restoring the balance, an important step. And how does it do that? It does that with process improvements. It streamlines the process, puts in effective deadlines, and provides for an automatic approval, something that was in the statute for a number of years. It also creates an expedited process. It also puts into place legislative priorities of services that should be under the Certificate of Need program. It exempts certain services. We wish to have an ongoing conversation with the committee on some of the language in there, which we think can be tightened up or explained, and a conversation about the interplay between relocation on municipality and mileage. I think as currently drafted, it may lead to some unintended results, but we look forward to those conversations. And it transfers the cost market impact review to the Attorney General's office. As I said one of the last times I was here, we have never stood up here and said something should go to the Attorney General's office as opposed to the Office of Health Strategy or any other state agency. This belongs there. Substantively, it belongs there. The report from OHS has to go there anyway. They do the market work. They do the work related to antitrust. And it looks at a level playing field and ensures all entities, including private equity, are subject to CON. With respect to House Bill 5136, we oppose that bill, and I'll give you an example, two examples. One we've spoken about because it uses that language in Senate 9 again here about exempting from Certificate of Need those entities acquiring hospitals, those entities acquiring for physician practices except for hospitals. It allows private equity to continue to do that. But there's a mandate in this bill that requires a Certificate of Need for physician personal services agreement. That means if a hospital wants to have a relationship with a high-end specialty hand plastic surgeon, right? That we know we have injuries and we know that these are very limited, the expertise is very limited, that personal service agreement would now have to go through the Office of Health Strategy. We wanted to hire new physicians to go on call in an emergency department. Those agreements now would have to go through the Certificate of Need problem. If we wanted to hire Senator Gordon to come down and to do education work in one of the hospitals, that agreement would require to go through the Certificate of Need program. We do not support that. And one last comment, Senate Bill 9, Senate Bill 5316, and Senate Bill 440 cannot independently pass. They do not flow together. You can't layer one on top of the other. We have to pick a bill and put the CON in the bill, because if we do it in two separate bills, I put my old LCO hat on. The problem would be huge if we did that. And a final thank you to this committee. It's the last public hearing. I think I've testified at almost every public hearing. Thank you for listening. This committee is really a joy to testify in front of. You put the people in front of you through substantive questions, and thank you for that. I think you get at the issues really well. And you, in addition, you read the testimony that's submitted. We've submitted testimony with some specific language changes related to Senate Bill 1. So thank you, and I'm happy to answer any questions.
Thank you so much. There's a lot to talk about here. So if I heard you correctly, 440 is pretty much okay in every aspect.
With some language, I think, clarifications, we support 440, yes.
Okay, and what I can tell you or share with you is that the Office of Health Strategies is trying to address the challenges that they've had with private equity in the recent past with 5316, and that's what they're trying to get at through this bill, because private equity tries to slice and dice things, and it's trying to look at how can they be aware of what's going on and not find out a little late in the game. How can the state be aware of what's going on if we don't have a bill like that, or at least parts of the bill like that?
I would say that Senate Bill 440 gets at it better in a cleaner way to get at it. In addition, it also provides for a study to amplify or to look at issues. In addition, I think 440 gets at it in a better way.
Okay, so in other words, we are still having the protection without having that process and information, because some of that is burdensome to the entire process and the duration of that process, what it takes.
Correct.
Okay. I want to just look around, make sure none of my colleagues have questions. Yes, my co-chair has a question, Representative Kristen McCarthy-Vahey.
Thank you, Senator Anwar, and Jim, thank you so much for being here. It's always a pleasure to have you here with us, and I appreciate the conversation both here at the committee and outside. So you talked about the fact that the current process has significant delays and burdens, and earlier today, I know you were here, you've been here all day, as you always are. When Dr. Gifford spoke, she talked about the changes in that office and the fact that there were 0 or 1 attorneys at one point in that office. And just curious from your perspective in terms of whether or not you have anecdotally even experienced a shift and a change as those changes have occurred in staffing.
I have not heard that people are saying, okay, never mind, the system is now working. But let me try to, because I heard that and I understand absolutely what Dr. Gifford is saying, but I think I want to look at it a little differently, is that we are relying on the efficiency of the Office of Health Strategy in the Certificate of Need program because they currently have the staff to do it. Life happens. People lose their desire to do one job and decide to do something else. The statutes are the things that would govern the time frames going forward, notwithstanding the amount of staff that is in the office. I think it's great. I think it's terrific that the goal is to reduce the time frame. But in 6 months from now, if 2 attorneys decide they want to move to the Department of Social Services or someone else, we're back to where we are without making changes in the process. So I think it's great. We absolutely support and thank Dr. Gifford for doing that. But these statutes should live independently of how and when the office is staffed fully.
Understood, but statutory guidelines or not, there still have to be people in place, right?
Correct.
To do the work.
Correct.
So I hear what you're saying. You'd like to see that in there. You talked about the movement over to the Attorney General's office, and earlier today, the Attorney General talked about being able to have economists and others, you know, in your experience with the Hospital Association and working with hospitals who are acquiring other practices, who are the people who are the kinds of experts that they look to? Because certainly they're looking at the market. So who are some of the folks that they're talking with as they go through that process?
Is your question like specific entities or types of
types of?
They would be legal experts that know antitrust market share, because any acquisition of a hospital also needs to go through the FTC, right? and they have to present evidence and a filing with the FTC. So it would be those, whether they are attorneys, they're probably attorneys, market analysts, and economists. And then they work. Why we think it's an appropriate move is they currently work with the Attorney General as they're working with the FTC. So it is a specialized area, but the Attorney General's office has the expertise there related to mergers, acquisitions, and antitrust. So they have some of it there, where the Office of Health Strategy has to go out and actually have consultants and work with consultants to do it. There is some in-house there. I understood, and I heard the Attorney General talk about that they would need additional staff, and I think we'd be open to a sort of a transition period in order to get it there, applications filed after a certain date, to give us the opportunity to work through the budget issues.
Thank you. And I appreciate the reference to the earlier conversation, and whether it's additional staff or the ability to hire those experts. I think Senator Anwar perhaps earlier talked about the creativity of the financial markets, and we've seen that. And we've seen the results and the impacts. For example, in 2008, when we had very complex financial instruments that were used that then resulted in, tens of thousands, hundreds of thousands of people losing their homes. Here now in healthcare, we're seeing these different financial instruments being used, and these are people who speak, a language of the financial, just the financial background, expertise, etc., that many of us in government simply do not have. And so that's one of the things I think about when I think about, it's not just private equity. We use that term as an, kind of an overarching term. It's more than just private equity. And as the Attorney General said earlier, it's not that all of these options are necessarily the worst options, or we don't want to characterize these actors as all bad actors. We have a system that is set up to allow this. So I think, to Senator Anwar's questions earlier, the ability to review and regulate and provide the balance, that was a word I used earlier as well. It really is important. So I know that I will also just underscore and thank you for referencing that we have multiple bills. There are bills proposed by this committee, bill from the Office of the Governor, bill from the Office of Health Strategy, and there are competing sections within those that will have to be resolved. So we will need to get around the table and look forward to being in conversation with you as part of that. Thank you, Senator.
Thank you. And I think your comment about some forward-thinking flexibility is important, because I spent probably as much time as you did looking up REITs and reading what was happening in Rhode Island and Massachusetts and other states. And healthcare has gotten as challenging as it ever has been in my 23 years of doing this, and understanding the different governance structures, the different way in which healthcare is provided. And we need the ability to regulate and to look, which is why I talked about a balance. The balance is accountability, because we have to make sure that there's access to the patients and quick access to the patients. It ties it into some of the conversations that Tracy Wardich was having about hospice care, and how do we make sure and protect the home care nurses at the same time we know we need a quick referral. And so we've got to get the balance right. The balance is not there today. 440 goes a long way, we think, into restoring that balance. But as always, we're ready to have this conversation.
Thank you so much, Jim. Just wanted to explore this further. Earlier there was a testimony about physician practices, and private equity is trying to get their hands into everything, and they wanted to be excluded from this whole process. And I think the governor's bill and Senate Bill 9 sort of gives an exclusion for a certain time. That's what you're talking about, was the concern that you have, right?
Correct.
And what the Connecticut Hospital Association's perspective is that there should not be any exclusion.
Our perspective is, if a hospital's activity is required to go through certificate of need, any other entities doing the same type of activity should go through certificate of need. I don't blame the physician who stood up here. I don't blame him at all for not wanting to go through the certificate of need process. Even this committee in the legislature has acknowledged the problems with CON repeatedly. When we needed more children's behavioral health, we took them out of the certificate of need. When we wanted harm reduction centers to get up, if they could, we took them out of CON. Last year, we did the same thing with birthing centers. So there is this move that we're acknowledging that the certificate of need program is not working, and we're moving things out. Anything that's new that we want up and running, we're moving out. There's a flavor of that in 440, which we support. But I don't blame anyone from standing up and saying we don't want to go through that certificate of need program as it is. When we hear a year to get through a CAT scan, and they're reading all the articles on the length of time to go through the certificate of need program. However, our view is if a hospital is required, when we're acquiring a physician practice is required to go through the certificate of need, anybody else who has to do that. And the 440 is written, as I said, in a way that is pretty nuanced. It didn't talk about investment. It talked about in controlling interest, right? There is a distinction there, and 440 makes that distinction.
Yes. So since 2019, we've been trying to get a bill and address the CON issue, and now we have like 4 bills on CON alone, and then we're trying to figure out how do we navigate each 4 of them, because there were some profound testimonies today with respect to how do we manage this. Because there is a voice, rightful, that we need to do the minimum that we can get away with, and also recognizing the data is not supportive of ongoing CON. We've seen the bad experiences that have been there, and I think striking that balance is going to be the tricky part. It will require many hours of conversations, but I think the prism, and I said that to Commissioner earlier, Dr. Gifford, the prism that Office of Health Strategies is looking at is entirely from the 3 hospital and the disaster that we are still enduring collectively. And that's one of the prisms. The second prism that we are looking at it from the Public Health Committee's perspective is that we want the process to be efficient, but we also want it to be cognizant of the needs of the community right now. And so that disconnect needs to be connected collectively, and identifying that common ground and these are starting points of conversations. But I can tell you, these bills, as they move forward, will result in a number of different conversations. The governor's bill will go in its own format, and there will be different groups that will be having that conversation, but we will be in the midst of each one of those conversations and would make sure that Connecticut Hospital Association is as well. So
thank you. It is, and you're right, figuring out the best path for the 3 different versions is going to be a challenging one. I think that one of the concerns we have is the weight and breadth of all of these issues may make it difficult in the next 50 days to do there. And I'm listening to comments about what are the things that we need to do and what are the things that we need more conversation on. And so I heard a theme of that in today's hearing. I think there are key things that we need to do this year, and I look forward to having those conversations with the committee.